morning. Welcome to this ESC TV Roundtable. Inside the major theme of this year Congress, which is making global cardiology a global interest, we are talking about sustainability. And sustainability nowadays imply also the importance of taking awareness and knowledge about environmental issue, carbon footprint. And I got today my good friends and experts in the field, which are going to present their experience and their comment and their novel ideas on this topic. And first of all, I'd like to invite Paul Dendale from Hasselt University. He's going to speak about and to provide this idea and comment about how environment on cardiovascular effect. Thanks, Paul.
Thank you, Massimo. So I think the environment is a topic that is getting more and more important, and it has been neglected a little bit in the past as a real risk factor. Environment has two connotations. First of all, it is the place where we live, where we work, where we have fun, and the way how this is organized has an influence on our cardiovascular risk. You know that there is a move from rural to urban living, and cities have a lot of opportunities for increasing health. You have more access to hospitals, better education, these kind of things. But on the other hand, there are also risks involved in urbanization, such as more heat, less exercise, these kind of things. So the way we organize our environment is important for our health. And you know the concept of heart-healthy cities, so cities that really take measures to improve cardiovascular health, that's really gaining traction more and more. One of the typical aspects of the human race is that we spoil our environment, and that's called pollution. And pollution is a very important risk factor concerning cardiovascular disease. And as you know, the European Respiratory Society is fighting against air pollution already a long time, but what we know now is that more people die of cardiovascular causes due to pollution than in other diseases. And what are the effects of pollution on our health? We have, of course, air pollution with noxious gases and particles. These all cause inflammation, oxidative stress, endothelial dysfunction, and by that way increase the risks of cardiovascular disease. And you might be surprised to hear that if we look at the number of deaths in relationship to risk factors, pollution is second only to hypertension in causing cardiovascular death. It is more important than smoking, diabetes, other risk factors. And still, if we talk to our patients, we don't take the environment pollution into account. Apart from the pollution, the air pollution, we have, of course, also noise pollution. As you hear when you attend the conference, the noise level here at the conference is something like 65 decibels, whereas the healthy level is 53. So attending conferences might harm your health. Well, slightly. There is also light pollution, another way where we have impact on our lives. The omnipresence of light all day, all night, and screens where we look until late at night make that we have a disruption of our sleep pattern, and disrupted sleep patterns have impact on obesity, causes diabetes, etc. So that's another aspect of the environment that plays a role. We have, of course, heat. With climate change comes heat. Heat here in Europe has caused thousands of deaths this summer due to just the extra stress you pose on your body. And the heat has also caused enormous wildfires with, again, extra CO2 and extra particles in the air, which again makes things dangerous for our patients.
Sorry to interrupt you, but from the pathophysiological mechanism, how does they work, environment on our cardiovascular risk?
They come on in different ways, but for example, the most important pollutant is the particles with a diameter of less than 2.5 micrometers. These can, when they are ingested, inhaled, they can penetrate into the bloodstream and there cause inflammation, cause oxidative stress, and by that way cause an effect on endothelial function. And as you know, endothelial function is the basis for atherosclerosis.
But also noise, light pollution, that they trigger some inflammatory reaction that can, at the end of the mechanism of atherosclerosis.
In animal models, this has been proven indeed. Noise, of course, works via sympathetic stimulation. You know, if you're in a noisy environment, it gives some kind of sympathetic stimulation. And this overstimulation, you know, in our cities, the noise level is always above the safe level of something like 50, 53 decibel. So we are constantly submitted to noise.
Thank you. Dr. Kiko, sorry. Well, from Paul, we have learned that we have to take awareness, we have to take responsibility. How can we do in clinical practice? In your experience, what your advice?
Yeah. So yeah, my name is KKU. I'm from the National Heart Center in Singapore. I serve as the CEO. So I think that's one reason why I was asked to be here. You know, what can we do to reduce the environmental impact of clinical practice? I must say the first thing that came to mind is that we need knowledge and we need to understand the science behind some of what we do and how it might relate to the environment. Let me give a few examples. The first is the use of, say, nitrous oxide in our operating rooms. I just found out recently that the piping of nitrous oxide, you know, to the operating theaters, in some of our operating rooms, up to 90% is lost en route. So that loss of that 90% into the atmosphere through the walls is more dangerous than, say, carbon dioxide loss. How do we then reduce this? Do we change to canisters? Are there other aerosols or gases that we can use that are less dangerous for the environment? Those things can only come about if we have the knowledge. And of course, you know about desflurane and other anesthetic gases that are toxic to the environment. The other things that we know from knowledge is, of course, the devices that we use in terms of single-use catheters or equipment. What can be reused? How do we, what are the dangerous components that can be discarded safely? I think most clinicians do not fully appreciate that. The second point I'd like to make with regards to how we can reduce the impact of what we do is in culture change and in management decisions. So within my institution and my larger hospital group, SingHealth in Singapore, we have created sustainability councils, and there's now a group director that manages this across all our hospitals, is given priority, and there are conferences, symposiums, as well as officers within each institution that help with recycling, as well as messaging to reduce water usage, for example. I think the biggest challenge that we have at a management level is how do we measure the impact of what we do. There are studies that look at life cycle analysis of, say, cardiac cath, and we're able to show that, for example, that perhaps the use of disposable single-use devices account for X% of its impact on the environment. But the effort to measure that is very difficult and cumbersome. Do we have a better way? I think we need more research into this, and I wish I knew the answer, and perhaps all of you here can advise us on what those measurements would be. Perhaps just to end off my segment on what else we can do, I think that we really need to teach in our, for medical students, for our staff, that we really need to take care of the environment, and that culture change, I think, is a very slow one, but crucial. And at ESC, I'm so glad that we have such a session to help inform all of us in terms of what we can do to reduce the impact on the environment.
Yes, because we were discussing earlier this morning about also if you choose a kind of treatment, you can also affect also environmental carbon dioxide footprint. Instead, if you decide to treat a valvular disease as an invasive or non-invasive procedure, it can affect also what is the environmental changes. Is it correct?
Yeah, I think so. So appropriate use of technologies, appropriate use of tests is crucial in part of this, because if we do things that are not necessarily, essentially it is waste. And whether it is nuclear radioactive waste when we do a stress imaging scan, or the use of catheters or contrast, they contribute to the environmental burden that we impose. So I would say that they are all interlinked. Appropriate use, choosing wisely, making sure that what we do is informed by science as well as patient choice. I think those are important aspects that I think feed back to the environmental effect.
Thank you. Francis, Varian, let me, where are you working? You're based there?
So I'm based in Sheffield, and I'm here on behalf of the British Cardiovascular Society and their Environment and Sustainability Committee.
So you're really the right person here to share. We have discussed about clinical impact. What about research? How can our academic activity or research can affect environmental issue?
Yeah, absolutely. So there was a white paper in 22 from the Sustainable Markets Initiative, and they estimated that the impact of clinical trials on the environment was around about 100 million tons of carbon dioxide equivalent emissions. And if you were to put that into context, it's about the same size as Belgium. But actually, in a healthcare context, when we're thinking about the healthcare sector producing almost 2 billion carbon dioxide equivalent emissions, it's actually probably only about 5%. And you might think that that is small, but what I really think that clinical trials offer is that we're at the forefront of evidence-based medicine. And if we're the ones that are integrating sustainability routinely into our trial design and showing how we can do that, then hopefully that can provide a bit of a chain reaction and trickle down into the healthcare sector. And one of the ways that we can really do this actually is to look to our industry, and I'm not here on behalf of any industry, I'm not affiliated with anyone, but actually they do have a huge amount of expertise, and I've learned a lot from their green teams. Recently, J&J actually published in BMJ Open, and they published life cycle assessments from 7 clinical trials, and they looked at all the 4 phases of various different disease areas, and they actually found that from that 80% of all of the greenhouse gas emissions come from 5 main areas. So one is drug product manufacture and development, the other one is patient travel, and interestingly patient travel is the one that was consistent across all trials as one of the major emissions factors. We also have on-site monitoring visits, the laboratory samples and processing, and then of course the staff travel as well. So just by performing that assessment just gives you a bit of an idea of where you could perhaps find your hotspots. And where the hotspots are where you really want to think about potentially changing some of your trial design. And as I said, there are easier ways to do that potentially than necessarily just doing a full life cycle assessment, because that does require specialist software as you've required, and it's for kind of, I guess, a climate hobbyist a bit like me who's interested in it. It's not necessarily something that I would go to do, but industry are there and could potentially provide that support for you, as well as other academic institutions as well.
It's very important the way we become aware among ourselves, among our colleagues, among our patients as well. What can cardiologists can do to measure and to deliver sustainable clinical trial, in your opinion?
Really good question again. So I think everything has moved forward so rapidly over the past 18 months. And one of the key groups is the Low Carbon Clinical Trials Group, and they actually now have a website, which is the Sustainable Healthcare Coalition website. And that would be the first place to start, because actually what they've done is broken it down into 5 easy steps. And they've got lots of literature on there. They've also published in BMJ Open as well, if you want to look at it in more detail. But the emissions factors are now provided. And the first step really is to think about, you take the trial protocol, you can build an Excel spreadsheet from it, which is quite easy to do. I've done it myself. And then you decide what's called the boundary of your trial. So that means deciding what's included and what's excluded in terms of your emissions factors. And then you can go through the protocol, and I've done this with 2 different clinical trial managers, and we found it pretty straightforward. There's a little bit of terminology to learn in terms of perhaps what's in the foreground, which might be processes that you can directly control, and then also in the background, which potentially you can't control, such as utilities and things like that from a building, from the buildings that the trial is delivered. But what you can do as well with these 5 steps is, once you've got your emissions factors, is that you can start doing simulations for your trial designs to find out, again, where these hotspots are and where potentially you could deliver the same quality of trial but in a more sustainable manner. And I did this looking at things like adaptive and crossover designs, but one of the other things that you can just look at, even without necessarily changing the design, is actually thinking about decentralized clinical trials. And the FDA, I think, produced their final white paper last year, which looked at clinical trials with decentralized elements. And even though there isn't any sustainability really mentioned in that paper, all of the suggestions within that and recommendations really would deliver sustainable trial design. And it really comes down to a numbers game. Anything that we can do to either reduce patients or particularly reduce travel not only reduces the carbon footprint and the emissions footprint, but it particularly also reduces the cost. And I think that's also one thing to remember, is that if it is more carbon, towards more carbon neutral, which is what we want to aim for really, it's more likely to be cost effective as well.
Yes, it's very important. Also, cost effectiveness is becoming our more stress situation. Chiara, gentlemen, you're in Bristol, you're in London now.
Yeah, Royal Brompton Hospital.
In Brompton. Well, I don't know whether I read yesterday that the development of ChatGPT-4 will require the same amount of energy than that 3 days San Francisco needs. So this is an important issue. Machine learning, artificial intelligence has become a key part of our life. But how can we modulate or address this point in the clinical practice?
Yes, so indeed it's a big issue, and I think it's due to increase, in fact, even more. So cloud computing can account for 1.5, almost 2% of the energy consumption globally. So although it seems a small number, actually in the grand scheme of things, is actually quite a lot. And based on the data, this is due to double by 2030. So we're talking in a few years away. So it is indeed a big problem, and I think more, particularly at this conference, there's so much AI in cardiology, in all flavors. And so AI actually intrinsically is bound to use more energy, computer consumption, and so on. So it's a bit of tension there, that, once we want to use AI and increase the efficiency of what we're saying, on the other hand, we're actually now being very sustainable, but we actually might be sustainable by using imaging, because then we accelerate a lot of the processes. So I think the devil is in the details, as we heard, how we measure it. It's really challenging how we measure it in terms of the tools, in terms of really the metric, also the best metric to use. And to be honest, we can't improve what we can't measure. So I think that's really the first stage in all the various topics that we're discussing here. So I bring the perspective also cardiac imaging. Cardiac imaging is really central in cardiology, whether it's echo, nuclear, cardiac MR, cardiac CT. And obviously, the more advanced these techniques are, the more actually energy consumption they bring. Certainly, probably CMR is in fact the most, the use of electricity. So on one hand, the guidelines is indicated to do a lot of cardiac MR, but then the sustainability of that is not there. So I think we need to rewire, what KK was saying, how we approach this technique. I think we don't know enough, and I think more cardiologists, and it's nice to have the audience here, need to be more, versed with this new topic. There is also an element of really resistance to change, because this is a human behavior. We all do what we know how to do and what we always done. But actually, as we approach this, we want to improve the environmental sustainability of what we do in cardiology. Actually, it does require to change a little bit what we do. Is whether looking at, I like what you said about the patient's travel and the life cycle assessment also, KK mentioned. In imaging, is also very true that one of the biggest energy consumption or carbon footprint increase is actually patient's travel. And so the way to tackle that potentially is to create more hub and spoke models. So rather than having all these patients traveling to the hospital, maybe the hospital has to travel to them and have these community imaging centers, for example, which is something that in the UK we're implementing already. Maybe not so much for cardiovascular imaging, is more for general radiology. And so those centers actually exist already. So you put, for example, an MRI machine in the car park of the local supermarket, and then the patients go there to have an EMR, liver MR, those sort of exams. And so actually, some work at Imperial College in London has demonstrated the improvement of such initiative on the carbon footprint. So just to give you a sense, like an email with an attachment can create 50 grams of carbon dioxide. How many emails with attachments we send every day? Millions, right? So, but then it's also an incentive to say, okay, maybe we need to be a little bit more cautious, and self-aware of what we do and the implication that does have. So maybe we need to end up in a place where we send less emails, and maybe, more impactful, more to the point. And I think in cardiology, maybe in medicine in general, we probably sometimes do too much. When it comes to imaging, it's like, let me take yet another picture, and all of a sudden, you build these massive files, which then not only need to be analyzed, but they need to be stored. And that's where the carbon footprint then skyrockets. And then sometimes it turns out actually you don't need all these images to make your diagnosis. And so there is now a huge incentive to shorten these protocols, and rather to do, for example, cardiac MRI 1 hour, 1 hour and a half, as it used to be. Now it's really half an hour, 20 minutes. Less images, to the point, you answer your question, and that's it. And that has a massive environmental sustainability impact. It's also more convenient for the patient that doesn't sit there for an hour.
I like your approach, as well, Francis' approach, to be very practical, to give practical advice to our colleague, to ourselves, to our patient. And Paul, you are a cardiology physician doing prevention like myself. And then we always try to promote physical activity to our patient. How do you face the possibility to check how safe to do exercise outside, outdoor? How can you measure and you provide safe suggestion, advice to your patient? Also regarding physical activities, as you teach us, it's very important for your health.
Yes. Indeed, Massimo, that's a very good question, because we think that exercise, we know that exercise is good for your health, but of course when you do exercise you inhale more air, so more particles, so more attacks on your endothelium. And so the thing is that we first have to make patients aware that it can change, that they need to choose when they do exercise, in what circumstances they do exercise. And you now have very good apps that tell you what is the pollution level around your house or your work. You even have apps that show which is the least polluted way to take when you drive to the bike to your work, for example. So I think that for our patients, the message is exercise remains important, but you need to choose a setting. If it's very polluted outside, you can see it on your app, then you stay indoors, you do exercise in a ventilated fitness center, for example. If like in the evening after traffic is gone, often pollution diminishes significantly, then you can go out for exercise. But I think the level at which exercise is dangerous for your health regarding pollution, that's not well known. And I think it's mainly in the very high levels of pollution where you have to pay attention, especially for cardiac patients. For healthy patients, the vulnerability is somewhat smaller. But I think just knowing what you're doing, and you can easily check it on any app that measures pollution in your environment, it's the first step to take, I think.
I have a question for Paul, actually. As you were discussing this, one thing that I had worried about is the impact of food safety, or specifically microplastics and other contaminants in our food. How should cardiologists think about food safety, especially in the area of microplastics, what we eat?
Very difficult question. Microplastics is one of the new kids on the block. We produce like hundreds of billions of tons of plastic, and they end up in microplastics, and the microplastics, they end up in our food, in our air. So we inhale and ingest them. They are found back in our blood vessels, even in atherosclerotic plaques, you see microplastics. So it certainly has an impact. The obvious solution is, of course, produce and less plastic and use less plastic. As far as I know, there are no filters that allow extracting those microplastics. So we will have to take the problem at the core, produce less plastics and dispose of them in a safe way so that they don't get into the environment.
Yeah, it's a tough one there.
Yep.
Yeah. On that note, can I add also something else, talking about food and pollution, and that there was a paper published 2 days ago that they analyzed some of the content in beers, and not picking up on any company in particular, but actually had a long list of all sorts of beers, maybe up to 30 around the world, and they found concentration of gadolinium metal in the beers. And so then the article describes the fact that probably those beers, and then some more than others, in fact, concentration was up to 30, I can't remember the unit of measure, to 1. So there was a big difference. And because they were articulating that when they produce beer, they basically use the water and of rivers, whatever water, I guess, is available. And basically the water nowadays, rivers, lakes, do contain a component of gadolinium contrast, because we give so much of this contrast in medicine, not just in cardiac MR, but in all the MRI radiology applications, that this contrast gets excreted with the urine, so it goes in the bathroom, the toilet, gets flushed and cascade. And so essentially we're drinking, a metal, in proportion. Now, the health repercussion of this are still unclear, but I was a little concerned when I read this, because we're basically, potentially intoxicating ourselves every day, and it's not just the beer, but who knows, how many other things. So it's actually, this topic of environmental sustainability is actually massively important for us as individuals. Also, when you look at the higher rates of cancer in the younger patients, I've been shocked to look at some statistics, particularly cancers of the digestive systems. And, there are people now in their 30s, it's not uncommon to have bowel cancer. It's really, really concerning. And actually, I actually know some of those individuals personally. So yeah, it's quite shocking. The more we kind of learn and dig into this topic, the more we find.
I think to pick up on that one, of course, we have to eat. So in the end, we'll have to ingest some things that are not always good. But much of the impact of pollution is through inflammation and oxidative stress. And so one of the ways potentially to decrease the impact is to eat more food with antioxidants. And maybe in the future we'll use, let's say, vitamin C, other kinds of supplements of antioxidants combat the negative effects of the nutrition we get.
So we have a duty also to inform our patient regarding which is healthy and not healthy, which is also a matter of costing, because also healthy food is more costing than less healthy. I'd like to come back to Keiko. How can we measure in clinical practice the environmental dangers factors? And then you can, in order to be updated, to inform our patient on this.
So I think that's really a big question. I think the elephant in the room. Without measurements, we can't really act.
Exactly.
I think the classical way is to do a life cycle analysis at every point in, say, a procedure's journey. You measure the impact of every piece of equipment you use, every time or gases that are released. But I think that is very time consuming. I feel that as a profession, whether it is in medicine alone or cardiology alone, we really need a better way that perhaps there are some references that we can impute or assume for more efficient calculations. I don't think anybody has a perfect way right now. However, I would say that the environmental impact of clinical practice is not just in the direct cardiovascular procedures. There are other things we can do that we can learn from other professions or domains. For example, the cooling of our hospitals in countries like Singapore, where it is on the equator, is very hot, and we are cooled by air cons all the time. So district cooling technologies, electric vehicles that bring us across from point A to point B, may be other ways, and those are perhaps easier to measure because the consumption of energy for district cooling versus by block building can be more discretely measured. So I'll say that this is still an evolving science, and it is timely that we are involved in this.
Well, thanks to Francis, based on your big committee in UK, what do you feel is a barrier to increase awareness and to make it a practical intervention on to reduce carbon footprint?
Yeah, I think and in barriers is a really key question, isn't it? I guess from my personal experience, I actually have a bit of a background in climate science because I read geography at the University of Cambridge about 2 decades ago. But when I became a cardiology registrar, I actually wanted to have a sustainable healthcare practice and also be able to deliver research sustainably as well. And I just had no idea where to start, even with having a little bit of knowledge. And actually where I did start, first of all, was to go to the Centre for Sustainable Healthcare, and they do an introductory course online, and I believe that's open to anybody. And that really gave me a bit of a toolkit to start with, and my local trust actually supported that. And what they encourage you to do is to get really hands-on and come out with a project. And part of my project was actually education and awareness, and sharing resources that I'd accessed that could be more available to others. And so we took this through the British Cardiovascular Society, and we implemented it last year as part of an emerging leaders program for healthcare professionals to really try and get them to think about how sustainability could be incorporated into their leadership or management project. And we use some of the online material. So there is a SUSQI, so SUSQI, and it's a bit of a package in terms of giving you, again, that toolkit to work through. So we did this as part of the education, and then at the end of the year, they presented their projects, and not one person had managed to do it. So I think it just goes to show, although the interest and the engagement is there, it's so challenging to start something new. So we're going to try something different this year, a little bit of difference in terms of the practical application of it. But because it's so new and it is alien and it's not yet, in where we are in terms of integrating this sustainability project, you know, we're coming at it very late, aren't we? It's not something that's been taught through medical schools. And so getting on board with it, in addition to everything else that you have to do, is a real challenge.
This is a real challenge because there are some key leading figures in the world that don't believe it in the environmental trouble.
I actually have a question for you, Francis. You know, and maybe a bit controversial, so please don't throw stones at me. In Singapore, for the sharing of data, we say that if you are funded by government funds, you must share your data so that, you know, the science can grow and you don't waste time regenerating data for others to use. So that's a requirement. What if funders say you need to put a paragraph on what you're doing that is sustainable, and it counts to whether the grants will be awarded? Would you like that?
Yeah. I mean, yeah, personally, my opinion is that that should be part of grants, part of funding. We need as many ways as possible to start integrating it into what we do. And as I was saying earlier about trickling down from clinical research and clinical trials and the practice, if we start integrating that into our project applications, grant applications, reporting it in terms of our, you know, clinical trial outcomes, then maybe it will start to trickle through the rest of healthcare.
Paul?
Yeah, I think this is all about behavior change, and we
Absolutely.
are speaking about behavior change to our patients to make them move more and smoke less and these kind of things. But we know that some government actions, legislative actions, can be very effective in producing change of behavior. If you tax cigarettes more, then there will be less smokers. And I think in this way we could also say, okay, this is something you need to comply with, and by that way force people to change their behavior. And for example, if I would like to suggest a very good measure to take now immediately is to ban all motorcycles. Motorcycles, it's not well known, a motorcycle pollutes at least 10 times as much as a car and makes a hell of a noise, we all know. So if you do like they did in China, throw them all out, and they probably started immediately with using electric bikes. So we have these low emission spaces in our big cities. Cars can't go in, but motorcycles can get in. So if we would get legislation saying, okay, we phase out the classical motorcycles in the next 5 years, you would have an impact on noise and on particle pollution. So these are kind of measures that if we can convince the European Union or the government to take these measures, then you have an impact on everybody at once. And of course you don't have to forbid everything, but sometimes legislative action can help, and I think it has to happen, because otherwise if we let everybody do his thing, then climate will deteriorate further and we'll have more and more problems.
Well, we are talking about barrier, how to overcome the barrier, and Chiara, that you're working in environment with imaging. This is what you feel the barrier amongst your colleagues to overcome. How you see the future?
Yeah, so in my experience, I've been passionate about reducing the footprint of cardiac MRI in particular, so I've been working in trying to shorten the protocols. My other role, I'm the CEO of the Society for Cardiac MRI globally, so we wrote a position paper to say cardiac MRI from tomorrow got to be half an hour. Actually you can answer the question in most clinical applications. Now, the implementation of that has been very sparse. And you know why? Because resistance to change. The radiographers want to do like a long scan, because all of a sudden, if you do shorter scan, you need to scan more patients, so they don't want to work more, right? So I've been quite actually intrigued by this kind of resistance to change. What is the root cause of that? And in one of my grants, I've been working with some psychologists to do some behavioral change interventions. And so that has required having a discussion, surveys, open group discussion, to say what motivates to actually be aligned with this environmental sustainability. People have different motivation. One is the ethical importance. For some people, feel more attached to this topic than others. You mentioned some politicians that they think this is, like doesn't exist. Other people, they don't want to create more work for themselves. So you need to be, mindful of that. And so an increased workflow, is not necessarily convenient. So we need to do the exercise, I guess, in our own environment to see what make people tick, which sort of values they align with that, and trying to work through those to actually achieve. But it's not a straight journey. It's really like this. So in my department, for example, in cardiac MRI, I've been trying to switch off the lights. Because notoriously, in any imaging department, you finish the day, you leave the MRI machine on, you leave the lights on. In the hospitals, I think how many of you turn off the lights, your corridors, your office? Do you turn off your computer, for example? Most people don't. You just, you log off and you come back. So just by doing these interventions, we'll be saving millions of electricity bills, for the hospitals. And there is a big radiology department in Switzerland that has done actually this piece of work. They say, you know what, from tomorrow we turn off the MRI machines, we turn back on in the morning, we turn off the lights, and they save 30% of the electricity bill. So it's massive. And this is something easy to measure because, you look at the bill, frankly. And also in the MRI machines, or in the CT machines, for that matter, now there is like a little meter that you attach to the machine. And so you read, how much you do if you do short protocol versus a long protocol, and so on. So I think we need to all be empowered to do, small things, but actually do matter, particularly in the large scale. If each of us from tomorrow turn off the computer in the office, for example, it's a massive initiative, and it really kind of empowers individuals. And then obviously, there is bigger, patients' pathways, that we need to redefine, and so on. So I think the journey is going along, but it's interesting because we are redesigning a new healthcare, right?
This is important. You're giving a final message. I'd like to ask all of you, we have got just 3 minutes, what is the most urgent task as a physician we can do now? Paul.
Well, I think we need to inform our patients that pollution has an important impact, and we need to take it into account if we speak to our patients, so that we are sure that they know about it, that they can measure it, and they can react to it. I think that's the one message I would like to convey. We need to know that it exists and it has a very large impact, and we can do something about it.
From Singapore point of view?
I would say the first thing is do not waste. If you don't need to do that, only do what's appropriate and necessary for the patient. Tied in with that is, as a clinician, is to make sure that we communicate and teach our future generations of doctors and healthcare providers that it's crucial to take care of the environment, because otherwise, we'll be left with nothing. Those 2 points.
Thank you. Francis.
Yeah, I think, the first point is that to action sustainability doesn't always require an upfront cost, and actually it can just be cost saving from the outset. And I'd really like to just encourage everybody to integrate sustainability just part and parcel of their personal lives, and also as a physician as well. I think that's really important, that you just try and ingrain little by little that behaviour change that we've all mentioned.
Yeah. Chiara, what do you think about ESC should take as important? ESC and also ESC body, ESC association on this aspect.
I think the ESC is doing a great job because it has a committee that you're chairing to start. So I think that's a good start. Really creating awareness, sessions like this, discussing the problems. And also I think we need to start doing the studies, the small observational studies, randomized trial, because we need more evidence. When you look at the sustainability literature, it's a lot of review papers and a lot of this epidemiological data, but we actually need to start doing small intervention that we measure the difference and then we move forward. It doesn't need to be a massive study, even a small. So I'm trying to play my role in the imaging department to do my small changes, turn off the light, turn off the MRI machine, that potentially, it's simple. Every little thing matters.
Yes, I see. Well, I was looking at the people coming to the Congress today. they're not always everybody wearing ties, and just also thinking about having a bottle, their own bottle, not plastic bottle. I think the sensitivity, at least among our colleagues, is rising. What is, I think, the major is to expand and increase awareness outside also our strict group of people, a group of friends. Well, with this, I'd like to thank all of you for your great experience. I learned a lot from you and from your, and I think also this was just one of the first steps that should develop also in the future. Thank you also for the audience who has participated to this conference. Thank you very much.